Welcome everyone to this webinar series from the Association of Physicians of Great Britain and Ireland. I'm Dr Uazman Alam and I'm a clinician scientist and reader at the University of Liverpool. I'm also an honorary consultant physician in internal medicine, diabetes and endocrinology. We'll be discussing and exploring diabetes and its complications today, specifically painful neuropathy, atrial fibrillation and global health research. I'll be moderating the session today. We have three excellent speakers, international leaders in their own right, who will be presenting on this webinar. Professor Gregory Lip from the University of Liverpool, Professor Solomon Tesfaye from the University of Sheffield, and Dr Anupam Garrib from UCL. The webinar will be available on the Association of Physicians YouTube channel, and for any questions, please insert them into the Q&A. So next, I'd just like to introduce Professor Gregory Lip, who is a Price Evans Chair of Cardiovascular Medicine at the University of Liverpool, and is also Director of the Liverpool Centre for Cardiovascular Science at the University of Liverpool, Liverpool John Moores University, and Liverpool Heart and Chest Hospital. Professor Lip has a major interest in health data science and the epidemiology of atrial fibrillation, as well as the pathophysiology of thromboembolism in arrhythmia. He's undertaken some seminal work, which includes CHAD-VASc and Hasbled score. This is for assessing stroke risk and bleeding risk. And this was first proposed independently and validated following his research, and now is incorporated into international guidelines and helps physicians like myself when we're working at the front end of the hospital in understanding who should be initiated on anticoagulation in atrial fibrillation. He's also spent half of his time as a clinical cardiologist working in atrial fibrillation and hypertension specialist clinical services and also acute cardiology. So without further delay, I'd like Professor Lip to introduce Professor Lip.
Thanks very much, Uazman, for the very kind introduction. And I've been asked to look at the topic of atrial fibrillation and diabetes and why it really is a bad combination. So, if I can, my laser pointer does work, which is excellent. So here are my declarations of interest. I'm not going to read every line, but into context, everything I say or speak in this presentation with regard to these declarations. So we recognize diabetes as one of the reasons people get incident atrial fibrillation, but I also want to highlight the fact that it's a bad combination because in the patients with diabetes and atrial fibrillation, the combination is a bad prognostic outcome. This is from the European Society of Cardiology EORP registry, a number of European countries involved in this registry. And I think you can see from this work that we published that diabetes, the presence of diabetes was independent risk factor for major adverse cardiac events, as you can see here, as well as all-cause mortality, as well as cardiovascular mortality. And I think, at least from the atrial fibrillation perspective, the presence of diabetes clearly adds to prognostication. They are high-risk patients, and these patients need to be managed proactively and in a holistic or integrated manner, and I'll come to that shortly. We see this in other parts of the world. This is data from Asia, and as you can see again, same pattern in the presence of atrial fibrillation, and more importantly now looks also not just at the risk of macrovascular complications, but also looking at the diabetes-related complications. And this is a nationwide cohort study. This is Korean data. And as you can see, compared to no atrial fibrillation, the presence of atrial fibrillation in diabetic patients increased risk of macrovascular complications, increased risk of nephropathy, increased risk of diabetic foot risk, although as you can see here with retinopathy, this was not statistically different. So you cannot say, certainly in the diabetic population, if there's associated atrial fibrillation, you can see this associated increase of macrovascular complications, nephropathy, as well as diabetic foot risk. Now, in terms of managing diabetes patients, there's a whole game changer now, because we now are in the era of diabetic drugs that have a major impact prognostic impact in relation to cardiovascular outcomes. And I don't necessarily need to go through all the detail. The pattern is much the same. And this is with the SGLT2 inhibitors, empagliflozin, canagliflozin, dapagliflozin, etc. If you compare them, compare these drugs to control a reduction in major adverse cardiovascular events, and I think the striking reduction in heart failure hospitalizations with regard to the use of these drugs. And I think the translation of these clinical trials, these are, of course, in the diabetic patients with associated cardiovascular disease. I've already mentioned in the association of atrial fibrillation and presence of diabetes are high risk of cardiovascular disease. These trials were not specific in atrial fibrillation patients. They were basically in patients with CVD, with cardiovascular disease. But if you look at observational data translating this information to practice, these are data from Taiwan. This is looking at SGLT2s versus GLP-1 receptor agonists and outcomes in diabetic patients on the left with atrial fibrillation, on the right without atrial fibrillation. The striking bit is from, as seen in the previous slide, from trials, this impact or this beneficial impact on heart failure hospitalizations as well as kidney outcomes in favor of the SGLT2s. Now, the SGLT2s are not the only drugs clearly for diabetes. And if you want to look at SGLT2s, you want to look at GLP-1 receptor antagonists and their combination in type 2 diabetes. And this is some analysis done together with our moderator, Dr. Alam, today. And this is quite a busy slide with lots of outcomes, but essentially this is clearly a forest plot. The first is for the risk in relation to SGLT2 use. Second one is for GLP-1 use and the combination. The striking bits are, you see this additive benefit of SGLT2s on top of GLP-1s, GLP receptor antagonists, and their combination, particularly for all-cause mortality, for hospitalizations, and this striking benefit again on heart failure when compared to controls excluding these medications. Now, for the sake of completeness, I just want to mention these two trials. These were patients in heart failure with reduced ejection fraction, hence leading to the SGLT2s, even presence or absence of diabetes. These are drugs already in the heart failure pathway, heart failure management pathway, given these trials such as the EMPEROR Reduce and the DAPA-HF trials, again, consistently showing this reduction in cardiovascular death and heart failure hospitalization in the heart failure population, as well as this reduction in heart failure hospitalization. So, apart from the standard regimes in relation to treating heart failure, now added to that is the fourth pillar, which is the SGLT2s. So, what about in patients with diabetes and the relation to incident atrial fibrillation? So, this is data again from Asia, and this is from Hong Kong, and we were looking in relation to SGLT2s, GLP-1 receptor antagonists, and the DPP-4 inhibitors, as mentioned there. So if you're looking in relation to comparing SGLT2s versus GLP-1s, you see here SGLT2s significantly better in relation to incident atrial fibrillation. Here we have SGLT2s versus the GLP-1s. Again, SGLT2s better in relation to incident atrial fibrillation. And the GLP-1s and the DPP-4 inhibitors, not significantly different when it comes to observational data in relation to incident or new onset atrial fibrillation. So with the SGLT2s, you see the possibility here of preventing the onset of atrial fibrillation, and therefore the added risk by combination of both atrial fibrillation and diabetes. What about atrial fibrillation-related events? And here is a study looking at the outcome of heart failure hospitalizations, urgent hospital visits, or cardiovascular death. the top here is the combination from the different studies, trials, and the bottom are the non-atrial fibrillation. I think you see this fairly consistent, whether the presence of AF or no AF in relation to the composite outcome of heart failure hospitalizations or cardiovascular death in the trial populations. Now, what about patients with atrial fibrillation and the impact of SGLT2s, in this case, empagliflozin, on heart failure and on renal outcomes in relation to the presence or absence of atrial fibrillation? So these are patients with type 2 diabetes, and the fact they were in the EMPA trials, they had established cardiovascular disease. The first point to make is, no surprise, AF patients at higher rates of events than non-AF. I think we showed that on the first couple of slides. And what you do see, irrespective of AF yes or AF no, this significant benefit of empagliflozin compared to placebo on the cardiovascular death or heart failure hospitalization, similar impact, p-value for interactions non-significant, similar effect size for cardiovascular death. There's heart failure hospitalization, wider confidence intervals in the smaller cohort there for presence of AF patients, mortality reduced, diuretic use as a surrogate here, first occurrence edema, and worsening nephropathy. So in the patients with type 2 diabetes at established cardiovascular disease, who have associated atrial fibrillation, and the impact or the benefit of empagliflozin representing SGLT2s is as good or similar to that seen in the non-AFib population. Now, this has spawned, of course, various systematic reviews and meta-analysis. This is one published a few years ago now, SGLT2s, and in atrial fibrillation and type 2 diabetes. I think it's probably the first column here is SGLT2s, then we have essentially placebo. I think the benefits are seen for most of the primary outcomes: incident AF, mortality, heart failure, secondary outcomes such as urinary tract infection were high in SGLT2s, as we recognize this from clinical practice. And I think this is an important game changer when it comes to the management of high cardiovascular risk patients with regard to the new drugs such as the SGLT2s. Now, I want to turn to another endpoint, which is dementia, because this is clearly, with the aging population, you could almost say is a growing tsunami of risk of such patients in the population. Their patients are living older, but they have more associated multimorbidity and cardiovascular disease. And this is from the Taiwan nationwide studies. And I think what you can see here, in relation to up to 5 years follow-up, the SGLT2 use associated with a reduced risk of incident dementia, particularly vascular dementia. And you also see less atrial fibrillation events. You also see less strokes. You see less mortality in the SGLT2 treated patients as well. And this is even with a competing risk analysis here. This was seen in the Trinetics dataset, which is a global federated health network dataset, and large numbers of patients here, and at 3 years follow-up when compared to patients not receiving, this is the hazard ratio in patients who are not receiving an SGLT2 compared to those who receive an SGLT2. Those not receiving SGLT2, higher risk of stroke, high risk of intracranial bleeding, incident dementia, incident heart failure, and higher mortality as well. So you can say that really, in terms of the game changer with regard to these drugs, they seem to, I think I emphasized the impressive impact on heart failure. Seems to be certainly some benefit in patients at high cardiovascular risk from atherosclerotic disease, some impact on renal outcomes, and in atrial fibrillation patients, clearly a lot of data there also showing benefit in these drugs. But can I just emphasize that in the management of atrial fibrillation, the management of diabetes and particularly with the evidence of the new drugs is part of this overall concept of holistic or integrated care management of atrial fibrillation. Turn to any textbook, turn to any guideline when you come to managing atrial fibrillation. It covers stroke avoidance or stroke prevention. That's the A. The B is better symptom management, patient-centered, symptom-directed decisions on rate and rhythm control, and the impact on cardiovascular and comorbidities, including lifestyle factors, including psychological morbidity, and the patient preferences and values. And this, of course, is the recommendation in a number of guidelines globally, and is supported by randomized trial evidence. If you turn to recent guidelines from the US, these are the so-called pillars of AF management, and you see they are color-coded. Same thing, covers the same thing. They've just done the acronym and done a bit of Scrabble, change it around. That's this stroke, modify our risk factors, that's symptoms. And if you turn to the European guidelines so it's essentially saying the same thing, they are equivalent. I suppose here you can say it's the implementation of this. The patient comes to my clinic when maybe elderly, maybe totally asymptomatic, perhaps slightly scared. What you can do is mention to the patient the plan of management or the patient pathway. It is A, avoiding a stroke, B is managing symptoms with rate or rhythm control, and C is the cardiovascular comorbidities. You can say it's easy as A, B, C, or you can take the American approach, it's an SOS, or the recent European guidelines, they changed the acronym round again to become CARE, cardiovascular comorbidities, which is obviously relevant in any cardiovascular condition like atrial fibrillation. Then you have avoid stroke, symptom management, and then the evaluation and dynamic assessment. So you say handle with care. So what's evidence, what's eminence? Well, these are data that we recently presented. We have published an earlier version of this with slightly fewer numbers, but adherence to the ABC pathway translates to mortality reduction, as you can see, of over 50%, 49% reduction in stroke, and 23% reduction in major bleeding. We have tested this in a prospective cluster randomized trial. This is the MAFA trial. This was ABC pathway delivered by an mHealth solution. And if the primary composite outcome is shown here. So as you can see, the p-value of interaction is not significant, irrespective of whether diabetes was present or absent. And you see also the p-value of interaction for bleeding events not significantly different. Some of the other outcomes, it was, as I say, there was a slightly different p-value significant because again, you will see here for the diabetic patients, confidence intervals was wide, but with the mHealth technology, there was perhaps greater patient contact, and then these endpoints were perhaps better or earlier picked up. But the primary trial outcome was stroke, death, hospitalization. There was no significant difference. We see here this as a forest plot here, the primary composite outcome, p-value of interaction not significant. As you can see, diabetes or no diabetes, there's about a 2/3 reduction in favor of ABC pathway adherence or compliance compared to usual care clusters. Now, I would stress that the components of ABC pathway are additive to each other. This is a study in AF patients with diabetes. We looked here in early rhythm control. So this is rhythm control, that's the B component. This is lifestyle modifications, in other words, the C, risk factor and lifestyle modifications. So focus on the outcome of stroke, and you can see also for macrovascular disease. You see that early rhythm control associated with less macro stroke and less macrovascular disease with early rhythm control and with lifestyle modification. But look at the additive benefit here. So this is here in green, lifestyle modification. In blue is the early rhythm control, and in red is with combination. You see this almost stepwise benefit by the combination of rhythm control plus lifestyle modification. So, ladies and gentlemen, let me sum this up. Atrial fibrillation and diabetes, a bad combination. They are both common conditions. If both are present, cardiovascular risks are substantially increased. SGLT2s particularly have been a bit of a game changer in this spectrum of cardiovascular conditions, even in the non-diabetic patients. You see this in diabetic and non-diabetic patients. There's the impact on heart failure, leading to its incorporation into guidelines for heart failure management. There may be renal protective effects, including as well as the benefits in heart failure, preserved ejection fraction. In type 2 diabetes and cardiovascular disease, the reductions in major adverse cardiac events, including those related to atrial fibrillation. There's lower rates of incident atrial fibrillation, recurrent atrial fibrillation, and atrial fibrillation-related complications. And with that, thank you for your attention.
Thank you very much, Professor Lip, for that very enlightening talk. I think we'll be taking questions at the end. And for the attendees, if you put your questions in the Q&A box, we'll take them at the end of the 3 talks. So next, I would like to introduce Professor Solomon Tesfaye, who's a professor of diabetic medicine and the research director of diabetes and endocrinology at the University of Sheffield. His research projects include epidemiology, risk factors, and pathogenesis of diabetic neuropathy. He has essentially changed our thoughts in regards to the way that diabetic neuropathy and neuropathic and painful diabetic neuropathy develop, particularly in relation to central nervous system involvement. So there's certainly been a paradigm shift from the work that he's undertaken. He's the past president of the NeuroDiab, which is the international working group for diabetic neuropathy, and he's also been involved in and chaired the International Consensus Panel on Diabetic Neuropathy. He's published in a number of journals, including New England Journal of Medicine and The Lancet, and his seminal work includes the EuroDiab study, Combo DN, and Option DM trials, all of which have made a fairly significant difference to clinical pathways. So without further delay, I'd like to introduce Professor Solomon Tesfaye.
Thank you very much indeed, Uazman, for that very kind introduction. Good afternoon, ladies and gentlemen. Let me put this in presentation mode. So my title is Advances in Pharmacological Combinations for Painful Diabetic Neuropathy, in particular with an emphasis with our recent trial, the Option DM trial published in The Lancet. These are my disclosures. So I'm going to talk briefly about the underdiagnosis of DPN and painful DPN, diabetic peripheral neuropathy, the monotherapies we have for painful diabetic neuropathy, and the confusing guidelines, Option DM trial, finish with very brief conclusions. So let's kick off. So diabetic neuropathy is a distal axonopathy, and it affects 50% of all people with diabetes. So 2.5 million people in the UK have diabetic peripheral neuropathy. And of these, half of these have painful diabetic neuropathy, 1.25 million people. So it's a very common disorder. It has peripheral manifestations. And if you take skin biopsy, there is a reduction in the intraepidermal nerve fibers. You can see here they're absent in a patient with distal symmetrical polyneuropathy or diabetic peripheral neuropathy. If you take a biopsy of the sural nerve, these are the myelinated fibers. There's a significant reduction, as you can see. When we then look at these blood vessels within the nerve, they are abnormal. These are endoneurial capillaries with the nerve, within the nerve tissue, and they are almost closed up with increased basement membrane thickening, endothelial cell proliferation, with almost vessel occlusion. So it's a microvascular disease. It's a microvascular complication of diabetes. And you can see also when you look at the blood vessels on the peripheral nerve, the sural nerve, at high magnification, it's only 2 millimeters from there to there. You can see artery and vein running parallel along the lengths of the nerve in a normal diabetic. In a patient with diabetic peripheral neuropathy, the arterial attenuation and with almost varying caliber, joining the vein in a direct arterial venous shunt, upon which the vein then becomes distended and tortuous. High pressure within the venous system. Why? Because it's bypassing the nerve. because the blood vessels within the nerve tissue are all closed up. So there is increased flow within the venous circulation, but impaired nerve blood flow within the nerve tissue. So it affects the nerves here. So it's a distal axonopathy, and then one is well established in the legs, the upper limbs are affected. But then also it has central manifestations. There is a reduction in spinal cord cross-sectional area. There is a reduction in cortical thickness is reduced. So abnormal sensation here over time affect the central nervous system. And here we find there is hyperperfusion in the thalamus, in the anterior cingulate cortex, in patients with painful neuropathy. So here there is no difference between painful neuropathy and painless neuropathy peripherally, but centrally there are central biomarkers of painful neuropathy. I don't have much time to develop these, so I'll carry on. Now, a study that we published many years ago showed that what drives diabetic peripheral neuropathy are vascular risk factors such as hypertension, smoking, abnormal blood glucose as well, change in blood glucose, there's a 7-year follow-up this, and obesity, triglycerides. And these are the, if you like, the drivers of peripheral neuropathy, the risk factors for peripheral neuropathy. But we do not know the risk factors for painful diabetic neuropathy. They are not known, because pain is really psychosocial aspects that influence, cultural aspects have an influence in pain. Pain is very complicated. You cannot reduce it to metabolic factors. But diabetic neuropathy is driven by modifiable risk factors. We can actually have change in outcomes in pain in diabetic neuropathy. Now, painful neuropathy is characterized with these symptoms: pins and needles, burning pain, electric shock type pain, painful cold, tingling or paresthesia, pins and needles. All these characterize painful diabetic neuropathy. And you can also have numbness, dead feeling in your feet. And unfortunately, this chronic pain has an impact on sleep, has an impact on mood, depression, and anxiety. In 50% of all people with painful neuropathy, there's mood disorders of anxiety and depression. And many patients also experience a number of problems: sexual functioning, other comorbidities of diabetes, walking ability, side effects from the many drugs that we give these patients. And the end result is that the patient becomes incapacitated. They have dysfunction, inability to function, inability to go on shopping, and they become socially isolated and really disabled. Now, this is a study which we did a year ago in 4 European countries, and you can see that only 1 in 2 patients with painful neuropathy are diagnosed currently, even in the UK. And this is Spain, Germany, and Netherlands. These are developed countries. Unlike retinopathy, it's diagnosed in 95–100%. Kidney problems are diagnosed immediately by doing blood tests. But nobody asks the patient, do you have pain in your feet? And characterize this at the general practitioner level. And in fact, most diagnosis is made by the diabetes specialist rather than the GP. But really, the GP should be the ones that diagnoses this condition in primary care. And patients are referred to a neurologist, a pain specialist, internal medicine specialist, and others. And nobody takes that responsibility. Retinopathy, you send them, they have eye screening, and then with changes, they immediately go to an ophthalmologist if they need treatment. Here, the referral pathways are not well defined. And often neuropathy is very advanced before it's diagnosed. We use Stone Age implements such as a 10-gram monofilament test. Can you feel this? This is not sophisticated. And many patients, by the time this becomes positive, actually are attending the foot clinic, where the mortality in the foot clinic over 5 years is 50%. It really is shocking. And these are really Stone Age implements. And so the International Consensus Panel, which I convened many years ago, we invited really leading experts from all over the world: Mayo Clinic, Harvard, all the top units in the world. And this panel, we published this paper in 2010. It's been cited almost 4,000 times. It's a seminal paper on how to diagnose a condition, how to manage it. And this panel said symptoms and signs, bedside tests are not adequate to confirm diabetic peripheral neuropathy. In addition, you need objective measures to confirm it. I don't have time to develop this, but what we've started in Sheffield is combined foot-eye renal screening program. And so the patients have eye drops put in. Almost everybody attends eye screening, 90% uptake, whereas a foot screening is done badly in primary care. Around 50% attend for these screening. So we did this screening at the eye clinic where the patients are scared of going blind. They attend this annually. And what we do is then we use sophisticated equipment. We measure nerve conduction using the sural sensory conduction velocity and amplitude is measured using in 3 minutes. We measure small fiber sweat function using pseudoscan, but there are others also, corneal confocal microscopy. Professor Uazman Alam and Riaz Malik have developed these techniques, corneal confocal microscopy. And there are other ways of diagnosing the condition early. We also ask them if they have painful neuropathy using this questionnaire, which takes just 2 minutes. So all these takes around 10 minutes. And then they have all the blood tests for cholesterol, for their blood pressure, body mass index, everything done within 30 minutes. The patient lives. This we call one-stop shop, the Sheffield One-Stop Shop. And this is being implemented all over the world. And you can see if you use the monofilament, you diagnose neuropathy in 14%. Use the DPN check, the handheld device, developed at Harvard, you diagnose neuropathy in 50%. A new diagnosis of painful neuropathy in 25% because we're using standardized questionnaire. And the patients love this service because they have everything done and they go instead of 6 visits to the GP. And we started doing this in the community, in big GP hubs. We learned a lot from COVID. This is during COVID. So the patients come in and they register. They have eye screening done. They have done physical examination as well as these point of care devices examination done in adjoining. So they have everything done in one go. They have all the blood tests. And these community one-stop shops were very successful. And once they are diagnosed with painful neuropathy, then they come to our painful neuropathy service. And the podiatrist can refer directly to our painful neuropathy service, where we have a number of treatment modalities. We tailor the treatment to the individual patient, depending on how bad the painful neuropathy is. Doctor, nurse, physiotherapist, pain specialist, psychologist, podiatrist, we all work, a physiotherapist. And neuromodulation, we're increasingly using spinal cord stimulation for intractable painful neuropathy, complementary therapies, counseling, behavior therapy, assistive device for elderly patients, particularly because of the neuropathy and the pain, they have difficulty in mobilizing. But the backbone of all this treatment is pharmacotherapy. So what treatments do we have? We have the monotherapies. There are 4 first-line drugs for painful diabetic neuropathy, including duloxetine, gabapentin, pregabalin, the gabapentinoids, amitriptyline. And these are the 4 drugs we have: gabapentin, pregabalin, duloxetine, amitriptyline. And they're all first line. But we have confusing guidelines. Some guidelines put them as first lines. For instance, for pregabalin is first line, but the French downgraded it last 2 years ago to second line. Gabapentin is second line in some, first line by NICE and by other bodies, but second line by the American Academy of Neurology and the Canadians. And the same with TCAs and duloxetine. Why is this confusion? I'll come to that in a minute. It's because they've not been compared head to head. So we don't know which is the best drug we have for our patients because pharma industry combine, they compare their drug against placebo. And also, a couple of studies showed that combination treatment is beneficial. The combination of nortriptyline, a TCA, and gabapentin was found to be more efficacious than either at higher dose. So the combination treatment improved pain much better, but the small number of patients, as you can see, although it was published in the Lancet. So NICE does not recommend combination treatment. NICE says if you start with pregabalin and if it doesn't work or if you get suboptimal response, switch rather than combine with other drugs. So the whole thing is very confusing to clinicians because in clinical practice, we combine these drugs. So we came up with this option DM trial the last couple of minutes. And here I got the help of many leading figures, including Professor Uazman Alam from Liverpool that you can see. And we published this paper in the journal The Lancet a couple of years ago. What was the aim of this study? Which is the best drug amongst pregabalin, amitriptyline, duloxetine? Which combination is the best? Does combination treatment provide better pain relief than high-dose monotherapy? So we tried to answer 3 questions in one trial. It was a year-long trial because patients went through a blinded treatment for a year. It was the longest pain trial ever, and I'm ever so grateful to all the investigators, including Professor Uazman Alam. So here is the trial results. I'll just take a minute to describe this. So patients start on a particular drug, amitriptyline. They don't know what they're taking. It's all blinded. And with amitriptyline, you get the pain from around 6.6 to around 4.3 or that sort of range. And then when you added, if you have suboptimal response, you added another drug, we got an improvement, further improvement of NRS, is, from 1 to 10. So 1, and this is the main pain score, 24-hour average pain score, improved by 1. But if somebody responded to amitriptyline really well, they stayed on that drug. It improved it to less than 3, which is mild pain. They stayed on that drug. And the same for all the duloxetine, pregabalin. You can see that combination treatment consistently improved pain scores better compared to high-dose monotherapy. But if somebody responds well to one drug, you carry on with them. So the first point of the result is that all these 3 drugs had equivalent efficacy. The only superior drug was pregabalin because it had less side effects, adverse effects. The discontinuation as a result of treatment, emergent adverse events was less for pregabalin. But in terms of efficacy, they were all absolutely identical. The combination treatment was also absolutely identical. Nothing was superior than the other. But combination treatment improved pain relief compared to high-dose monotherapy. So finishing off then, Uazman, Professor Alam, ladies and gentlemen, combination therapy is now in the guidelines, as you can see, if there is suboptimal response to a first-line agent. And the one-stop shop, I hope, will spread because it really has been a game changer in Sheffield in early referral, early diagnosis, and early treatment for our diabetes patients. It's like a diabetes MOT. And I'm delighted to tell you that it won the NHS Innovation Award for 2021. And option DM trial, all the drugs have equivalent efficacy. Combination treatment is better, superior than high-dose monotherapy, and the combination treatments have equivalent efficacy. Pregabalin was the best tolerated drug. Thank you very much indeed for your very kind attention.
Thank you very much, Professor Tesfaye, for that beautiful and very enlightening talk. And we'll move on to Dr. Anupam Garrib, who's a Principal Research Associate in the Institute of Global Health. She's previously worked within UK Public Health as a Principal Public Health Strategist and also in clinical guideline development. She's currently working within Respond Africa Partnership, which is an equitable and inclusive partnership involving different stakeholders, including researchers, policymakers, patient and community representatives, and also healthcare providers. The work of this group is predominantly focused on HIV, diabetes, and hypertension. She's currently coordinating health system trials in the integration of care for HIV, diabetes, and hypertension, and is coordinating a phase 3 clinical trial of metformin for the prevention of diabetes in people who are living with HIV and pre-diabetes.
Thank you, Uazman. Thank you very much for that introduction, and good afternoon to everyone. Let me just share my slides. Oh, no, I don't think that's the one. Sorry, apologies. do it that way. Is that okay? I hope you can see that.
You need to change your screen.
Sorry. Yeah, I'm just trying to get underneath it. Oh, there we go. Here we go. Display settings. There we go. So, sorry about that. I hope that's okay. Is that all right? Can you see that?
We can see that. That's fine. Perfect.
Great. Okay. So, thank you very much. Sorry about that. So what I'm going to be talking to you about is global health research in diabetes. And I think this is probably a bit more of a general kind of a presentation than the ones that we've just been listening to. And my aim is really just to give you an introduction into some of the key challenges that are being faced in diabetes globally, and to give you sort of an overview of what's happening in diabetes globally. So this is a picture from the IDF Diabetes Atlas, showing prevalence of diabetes by region. And you can see that the largest numbers of people living with diabetes are here in this Western Pacific region, including China, and in Southeast Asia, so India, Pakistan, Bangladesh. But although the numbers are a lot smaller, the proportional increase over the next 20 odd years that we expect to see in the numbers of people living with diabetes is going to be happening here in the African region and in the Middle East and North African region. And the rise is largely being driven by changes in diet and lifestyle, increasing levels of obesity. And within different regions, there may be different factors that are driving the very high prevalence, including genetic factors, interaction between genes, and the environmental factors. And the fact that in some low and middle income country settings, there is very rapid urbanization and changes in diet and activity levels. So again, this is from the Diabetes Atlas, and it's showing you the proportion of people who died from diabetes before the age of 60. So this is focused really on premature mortality. And our previous speakers have given you a very good introduction into what diabetes does in terms of morbidity. And ultimately that leads to premature mortality if people are not able to access care. We know that diabetes contributes to premature mortality, both directly from the diabetes itself and also from its contribution to cardiovascular risk. So again, just to highlight that if in 2021, the largest, the region most affected in terms of premature mortality is this region here, where you're also expecting to see a doubling of the numbers of people living with diabetes. These low and middle income country settings we know already have health systems that are under-resourced, that are struggling to cope with the burden of infectious disease and non-communicable disease epidemics. We can imagine what the impact of the rising prevalence of diabetes is going to do to premature mortality. And I think the real issue here is that the burden of the disease on individuals, on families, and on the health system is absolutely massive, and certainly for individuals and families can be quite catastrophic from an economic point of view. So in November of this year, there was an article published in The Lancet that was looking at trends in diabetes prevalence and treatment over the last 30 years. And this study looked at an analysis of over 1,000 studies to look at those trends in diabetes prevalence. And what I wanted to show you in this particular picture is the number of data sources that were used in that analysis. And again, this region here, where premature mortality is high, prevalence is expected to increase, there's very little data available in this region. And in some of these countries, there are no data points and no data contributions. So we have very little idea of what's happening with respect to diabetes in this country, in this region, and in some countries within the region. So the study itself looked at changes in diabetes prevalence and how treatment coverage has been changing over the last 30 years. And they found that in some high-income countries, treatment coverage is really improved, but in a lot of low and middle-income countries, treatment coverage has not changed at all, despite the increase in prevalence. And in some countries, particularly in sub-Saharan Africa, coverage is as low as 10%. So about 10% of people who have diabetes are actually receiving care. This is a diabetes care cascade. So we know that in low and middle income country settings, almost half of the people who have diabetes won't know. So very, very high undiagnosed disease in these settings. Health systems are, because they're under-resourced, they're not screening people. People who are being screened are not being put on treatment. And those who do receive treatment are very, very poorly controlled. And the challenges that health systems face there is that there's a real shortage of trained, clinically qualified staff, shortage of equipment, care is not accessible. So in diabetes, often care is quite centralized. So it's not that somebody can go to their local clinic or, to a local pharmacy and access care if they want to. They may have to go to a bigger district level hospital, and the costs of accessing that care is very high. And there's very poor retention in care, poor levels of adherence and low levels of disease control. So what we do know is that kind of chronic disease model of care that's required for a disease like diabetes is very difficult in health systems that are sort of set up for dealing with infectious disease, because infectious diseases are acute. You come in, you have something, you treat it, and you go away, and you don't really have to have any continuity of care. But for within low and middle income country settings, there are examples, in particular HIV, where a chronic disease model of care has been implemented and has been successful. So HIV taught us a huge amount about what is possible in terms of chronic disease care delivery. It was a very special case. There was a lot of funding, a lot of resources, intellectual and financial resources that went into setting up a system kind of from scratch. So there was an opportunity to innovate and an opportunity to create kind of a platform of chronic disease care that has been really successful. And if you compare this care cascade to what's happening in HIV, most people who have HIV are aware of their status, they're being put onto treatment, and they're being adequately controlled. So the idea now is to try and utilize that platform that's been created for HIV care and see if we can expand the delivery of non-communicable disease care, diabetes and hypertension, onto that platform. And there's a lot of research going on around how exactly you do that, because obviously it's got to be done in such a way that doesn't compromise the HIV care programs. So a number of trials have looked at different models of how to integrate services for non-communicable diseases into the HIV care program, whether that is facility-based. And COVID changed quite a lot about how HIV care is being delivered. If there is a lot more decentralized care being delivered in the community, and so again, a possibility of diabetes and hypertension care also being decentralized into the community. And so several trials ongoing to see whether or not that works. Even if it does work, what we've seen is that the models do work within the trial setting, but implementing that sort of model at a much larger scale is the next kind of area of research. How do we go about scaling up models that have been shown to work in integration of HIV and non-communicable disease care? So I think the key thing here is that none of these things matter very much if we don't actually have access to drugs. In diabetes management, the variability of blood glucose levels is really dangerous, because that's what leads to development of complications and to management issues within patients with diabetes. Consistency of access to drugs is absolutely critical there. And this slide comes from a trial that was looking at, from a study that was looking at availability of diabetes medicines in sub-Saharan Africa. And the first-line therapies that are being used for diabetes are not new drugs, they're old drugs, they're drugs that are off patent, they're drugs that are cheap, but they're still not accessible, and they're not available in within the healthcare systems. So there, that in itself is a significant issue. So scaling up care is not really necessarily going to have much of an effect if drugs are not available. And of course, this is compounded by the lack of availability of data to support demand analyses, to support planning. It's very hard to plan how many drugs you need for people with diabetes if you don't know how many people have diabetes in any particular country. And I think just thinking here about some of the previous presentations that we've had and some of the newer therapies for diabetes that are becoming available, the SGLT drugs, the GLP-1 agonists currently available, the evidence is suggesting they're so much better at managing diabetes. They have far better profiles in terms of weight loss, cardiovascular protective effects, but there's almost no research being conducted on those drugs in very low income settings, certainly not in Africa. So the likelihood of those becoming available within those health systems is almost nil if health systems cannot afford to provide metformin. And this is really, it's an equity issue. And likely the effect of this is to widen the inequalities and to widen the gap in life expectancy between people living with diabetes in high-income countries and people living with diabetes in low-income countries. And health policymakers really need a lot more evidence. They need more data to be able to support advocacy efforts for increasing equitable access to drugs. And the lack of availability of drugs is really a visible thing for people living with diabetes in low and middle income country settings. So these are two papers from different parts of the world with almost identical taglines, both of them highlighting that having diabetes is in some places worse than having HIV. And that's because it's so difficult to access care and so difficult to access drugs. So we did a recent piece of work trying to determine in East Africa, trying to determine what is it that patients want from a screening system. How best would they like that to be organized to engage with it? And what they were telling us was it's not actually about the availability of the screening. It's the fact that once they're screened and if they're diagnosed with something, they don't know whether they're going to be able to access drugs. And the fact and knowing that they have a disease that they can't actually access treatment for is hugely stressful. So actually, they'd rather not know. If they're feeling well, they'll just wait until they start to feel unwell, and then they'll go and look for care. And they're going to start to feel unwell when they develop complications. And the outcomes for this, obviously, once you've started to develop diabetes-related complications, is so much worse. There's an emerging body of evidence that suggests that we don't really understand enough about diabetes in different populations. So thinking particularly about African populations, I mean, I think the idea that there are ethnicity differences in diabetes risk and diabetes presentation is not new. But again, there's very, very little data on how this might affect African populations. So there's some interesting work being done, but, as with all things research related, building the evidence base takes quite a lot of time. So there are large cohort studies in multi sites within Africa that are looking at the genetic associations and the interaction of genes in the environment and what effect that might have on development of cardiometabolic disease. Because most of what we know about diabetes comes from European populations, now increasingly also from Asian populations. But we don't understand enough about African populations. And that's really important because we need to know whether or not the treatments that we are using as first line, the prevention strategies that we are using are really best suited to these African populations. So a recent systematic review comparing studies from European and African populations found that in amongst relatively newly diagnosed diabetics, Black Africans at diagnosis had a much lower mean age. They had lower body mass index and higher median HbA1c. And interestingly, these data here, this is from a UK-based primary care database that was looking at age and ethnicity-related differences in body weight and various other factors at diagnosis. And you can see that at whatever age patients are being diagnosed, there's a large difference in body weight at which people are developing diabetes amongst European and amongst African and Asian populations. So I think what I presented to you are just a very few key issues that are sort of, being thought about within the global health space. There are many more issues, many more questions. I think that one of the main things is that there are very, very big data gaps that need to be filled. And both research and advocacy needed to try and reduce some of the inequalities in outcomes that we see in diabetes patients. We know that it can be done. It's been seen to work for HIV, but requires huge amounts of resources and huge amounts of input. And I think really to highlight that the lack of access to care is part of the developmental challenge for low and middle income country settings, because the economic consequences of morbidity and of premature mortality are really high for countries that don't have the resources to cope with it. Thank you very much.
Thank you, Dr. Garrib, for that excellent talk. It's very insightful. So we have just a couple of minutes left before the end of the webinar. I think there's a couple of questions. I think firstly, Professor Lip's just about to answer one about smartwatches and AF. I think he's been doing some work on this already.
I'll just answer that. I mean, if the patient has a smartwatch, then yes, of course, yeah, you're seeing more and more patients with these with their smart devices, etc. As long as they know how to use it in a responsible way.
So I'll move over to Professor Tesfaye, who's answered a few of these questions, but I think there's one very clinically pertinent question here from Professor Christian Delis, I think, from Glasgow. Thank you very much for a clear presentation. When patients have more than one reason for neuropathy, diabetes, B12 deficient, and alcohol, how does this change your approach to diagnosis and management?
Yeah, quick answer. I have actually written the answer to that. We always check B12 levels in all our diabetes patients, simply because there's a relationship with metformin now. It does cause, if there is deficiency, you have to replace the B12. With regard to the management of the pain itself, there's no difference. We all also take alcohol history, of course. If they're in any diabetes consultation, that's the first question: is how much alcohol do you drink? Because it has an impact on diabetes care. So obviously, we encourage reduction in alcohol intake if there is excessive intake.
Okay, excellent. Excellent. I think we have a little bit more time than what we thought. We've got another few minutes. Okay. So let me just open these questions again. So I think this one is to Professor Lip, and this is from me, actually. So I've got a couple of questions based on your presentation. SGLT2, are they actually an antiarrhythmic, given that the separations in the curves happen very early? Is this more of an antiarrhythmic effect, or?
I don't think it's an antiarrhythmic effect per se. I suspect, I would hypothesize it's probably related to the beneficial effects it has on cardiac functional status, risk factors, etc. And that's why it seems to reduce the risk of incident AF. The AF management, atrial fibrillation management, has, rather than thinking AF as a simple homogeneous condition, it really is to realize it is only one of a big picture, very often with multi-morbidity, clinical complexity, and diabetes is one bit of that jigsaw. So you manage the whole patient, not a bit of the patient.
Sure. And with the second question is about prediction of AF. So I know there's some data potentially even using artificial intelligence for the prediction of AF. You see utilizing routine ECGs, for instance. Is this something that maybe develops further? And what are your thoughts on this?
Well, it's there's a lot of interest there, and say using a simple 12-lead ECG to predict incident atrial fibrillation. There's various models to even do this. Very simple clinical risk scores in some position papers in the European Heart Rhythm Association, as well as from the recent American guidelines, clinical scores like some of those we proposed called a CHESS score, linking in clinical factors like coronary disease, COPD, hypertension, etc., is a reasonably good predictor. These are clinical scores, notwithstanding all of them have essentially about the same area under the curve in terms of the predictive value. You can have more complicated scores. Some of them require presence of looking at the left atrial size and looking at all kinds of things. The ECG per se, I suppose if it gets into automated apps and you could say front-end sort of AI systems on the desktop, you could say, well, this is a patient at potential risk of AF, advise, heavy risk factor and lifestyle management. So, but we're still a little bit away before we get this totally implemented into clinical practice.
Sure. And I think the next question actually is to yourself, Professor Lip and Professor Tesfaye. So are there any studies to say that SGLT2 could be helpful in type 1 diabetes? So I'll let Professor Tesfaye go first and then Professor Lip, cardiologist versus the diabetologist.
We do worry a little bit to start patients on SGLT2 inhibitors. I think Colin Diane probably is better suited to answer that question because of the risk of DKA in type 1 diabetes. But I have used it under very careful conditions, and it seems to benefit patients. So maybe I think Professor Lip might be better suited to answer this question, because these drugs are beneficial, but the danger of using them particularly can inadvertent decay in some of our patients.
I must say I have to agree with Solomon there, because I think about this also mechanistically. But I mean, we now the SGLT2 seem to be wonderful for all kinds of things. It's almost like you can almost imagine some deja vu from 20 years ago with the statins. It seems to be good for everything. So I think it's if there are associated comorbidities with the patient with type 1 diabetes, I don't think it's unreasonable if the patient has associated heart failure, etc. Or this would be. It seems to the SGLT2s also work in whether it's type 2 diabetes or non-diabetes. So there's no reason why it doesn't work in type 1 diabetes. In terms of cardiovascular risk, once they get these patients get older, they are also pretty high risk.
There's a question for Dr. Garrib.
There is indeed.
Do you want to answer, because you've not said anything yet?
Yeah.
Go on.
Thank you. Yes, I agree that education awareness programs very much needed. There are within countries, there is an awareness of it, but much more needs to be done. I think there is also the issue of stigma, because people do know that diabetes is not it's not a good diagnosis to have. There's a struggle to access care, and that people do develop lots of complications. So accessibility of screening is also lacking. So people don't want to have the diagnosis, and they don't want to share that they have the diagnosis. But absolutely, yes, education awareness very much needed.
And just touching upon the point in regards to some of the weight difference, there is obviously this phenomenon where people can have more of a cachexia type of picture with a diabetes or low body weight. And I don't know if you could just touch upon what maybe the prevalence of that may be and associated issues and treatment.
So I think this is what we don't know. How much of what the differences, sort of what sometimes is called the lean diabetes, is there are we seeing within these developing country settings? And I think there's a lot of work going on to try and describe phenotypes of diabetes and to try and relate the genetic information that we're having with the phenotypes of diabetes that we're seeing, and also the interaction between infectious disease and diabetes incidence. So I think that is an area that's quite rapidly developing, but there is not enough information at the moment to understand how much of what type of diabetes is present.
So you'd say that more prevalent studies, epidemiological studies, are required in that area?
Absolutely.
I mean, it's clear from the slide that you put up that there was actually quite low quality or maybe low levels of evidence in the Africa region.
There's very, very little evidence in the African region. And, you know, there are some sort of large, there are almost no, you know, maybe 3 or 4 major cohorts compared to hundreds of cohorts that you will have seen in European studies. And the evidence that we're getting is all still quite new. So I think it's very much of a sort of watch this space, but there are some very interesting groups in Uganda and in other places that are trying to, you know, develop our understanding of that.
There's a question for me quickly, Uazman, from Mahresh about the one-stop shop. Yes, we have published some work. If you look at the one-stop shop, we've started this in, for instance, in the Philippines. So the one-stop shop is a concept. You don't have to use these point-of-care devices if they are expensive. It's just doing an MOT, like in the UK. A car is, you know, we don't examine, you don't look at the engine in one garage, and it's having everything done in one go so that everybody, if there is an increased uptake of neglected areas, such as the diabetic foot. So if you would need to know about this, send me an email. I'll tell you how you can set it up. But this is all described in 2 papers we published recently. So the setup is not that difficult. In fact, it saves you money. It means that patients are seen in one go. They don't need 6 appointments to check the A1C, the blood pressure, and then another day to come for eye screening. You know, you do everything. It's just a way of organizing it. I hope that answers your question.
Thank you, Professor Tesfaye, for that answer. I think we're at the end of the webinar, so I'd like to thank all the presenters, the Association of Physicians, and namely Professor Lip, Professor Tesfaye and Dr Garrib for participating in this, and for everybody who is listening. So thank you very much.